And now we are moving to the next presentation by Dr. Ivani. Uh, Dr. Ivani completed her bachelor and master degree in science, in animal science with emphasis in reproductive physiology. She earned her Ph.D. degree in physiology as part of the Animal Reproduction and Biotechnology group at Colorado State University. Um, she currently runs an IVF laboratory. She is an IVF laboratory director at Reproductive Science Center in San Ramon since 1990, where she plays a key role in advancing the IVF field through adopting new technologies and scientific research in embryology. Um, Kristen, the floor is yours. Thank you so much.
Thank you very much, Nabil, and especially Riley for putting this all together, keeping us all honest here. And what an amazing cast of characters we have today. So I really am grateful for the opportunity to be here. This is one of those webinars where some people are going to sit and go, God, why do they do it like that? And other people will say, oh, we've been doing that forever. And we hope that everybody gets to pick up a little thing here and there. And if you learn anything, you'll learn that there's a lot of really right ways to do IVF. So I put together some slides, and I believe that, Riley, are you driving?
Are you able to control the screen?
Okay, there we go. Okay.
All right.
So we'll talk a little bit about ICSI. It's pretty tough to follow Tony Anderson because he did an amazing job talking about ICSI. This is one of our ICSI setups here. And one of the most important things when you're starting out, especially when you're first learning ICSI, is the equipment should work for you, not the other way around. So the last thing you want to be doing is wrestling and arguing with your equipment. And one of the most important things when you start up is to make sure that your tools are aligned. A lot of people do that on the objective, as you see in this picture here. Other people just freelance it right into the dish. One way when you're first getting started is to set them up this way, where you can see that your ICSI needle may actually go right into the hole in the holding pipette. Again, take the time to learn your equipment and make it work for you, not the other way around. Okay. And the next slide, for some reason, this isn't advancing, Riley.
Oh, no problem. I can just take over.
Okay, next slide. This is a video. Our ICSI is pretty mainstream. We put the polar body up at 12 o'clock, and you can see the sperm in the injection pipette. Get a good grip on your zona pellucida. And just as Tony showed, you're going to make a smooth movement through the zona pellucida, through the egg membrane. And we are aspirating at the same time you're pressing. You want to make sure that membrane breaks, aspirate some cytoplasm, and then really gently move your sperm, release it into the cytoplasm of the egg. Things look simpler on TV, don't they? In the next slide, we have, let me see. It's really important to monitor your performance in the laboratory. And we look at this every couple of weeks in our lab. And this is just a table of fertilization rates. This is all technicians. And the average fertilization rate is around 84% or so. And you can see that there's some little ups and downs. Again, this is all patients, all techs, all ages, including even testicular cases. But it's really important for you to have a good idea of what is going on in your laboratory at all times. And next slide, please. So in addition to the fertilization rate, you also want to monitor your degeneration rate. and your abnormal FERT rate. And this is data from 2019. There are about 50 or 14,000 eggs collected, 10,000, 11,000 eggs injected. Average fertilization rate is 84%. So you want your degeneration rate to be as low as you can be. This is, I think, for most trained technicians, we know that the degeneration rate is more a factor of the egg quality rather than the technical operator. And the next slide. The other KPI that you should be monitoring is the usable blast rate. And this is really important because it's great to get good fertilization rates, but if the embryos aren't growing into usable embryos for you, we have a problem. And so again, this is a table generated that we look at the data every couple of weeks, aiming for a usable blast rate, which is how many embryos are either vitrified or transferred, divided by the number of 2PNs. So you can see a couple of dips. The one on the left, one of life's big mysteries. Who knows? You can tear your lab apart. You can call all your friends. And oftentimes you're never going to find out what happened. The one on the right, as many of you know, we had really severe wildfires in California, Northern California, over the last couple of months, and we had extremely poor air quality. Now, we did manage to kind of ramp up our air handler to avoid some of that. It is inevitable that some of that is going to get into the lab. We have a VOC monitor. VOCs were normal. Everything seemed to be fine. We did see a dip. It may or may not have been as a result of that, but things back to normal, which makes everybody happy. And the next slide. So big question, and I heard David gave a nice presentation on hatching on day 3 or waiting until day 5. I will give you my personal take on this. Our question was, we know that the embryos expand more and may look better and have a more identifiable ICM inside if you wait until day 5. But do you really get more embryos to biopsy? Or are we just jumping on the biopsy or the hatch on day 5 train? So we did a little study in our lab for a month. And we figured, because we do a lot of biopsy, that a month would be plenty of time for us to determine this. And so, we like the embryo on the top. We like the embryo on the bottom too. We do not like to biopsy the embryos on the bottom. And kudos to those of you who do and are good at it, because we did not like it. Like, we had almost a mutiny on our hands. But the most important thing was that we did not see any increase in the usable blast rate, and we did not see any increase in pregnancy rates. And we find that biopsying them when they're herniating out of the zona like this is a lot easier, and it's a lot faster. And it wasn't harming the embryos, which is really what we want to see. So we do make a small opening, a small hatch on day 3 in the morning, first thing in the morning, and then we biopsy them in the morning on day 5. Next slide, please. Boy, if trophectoderm biopsy does one thing, it unleashes your creativity as an embryologist, because no embryo is the same. And you as an embryologist doing this are required to make split decisions on every embryo every single time you're going to biopsy. With ICSI, it's pretty standard. I mean, you might have some, not so great eggs, not so great sperm, but generally you're doing it the same way every time. The upper left picture shows, a really nice embryo. The ICM, lucky for you, is inside, a nice big fat piece hanging outside. The one on the bottom left, where the ICM is outside, but you can still access the trophectoderm. The one on the upper right is a fully hatched blastocyst with a nice ICM. And then the one at the bottom is a decision: is this ready to biopsy? Should we let it go another day? Are we going to risk damaging the embryo? So these decisions need to be made for every embryo. Next slide, please. So this is what I call trophectoderm biopsy the easy way. You have your trophectoderm biopsy herniating out. Your ICM is inside. We're going to stretch it as you saw in the previous videos. Try to hit the cell-to-cell junctions without going over and over the same piece so it doesn't get like a roasted marshmallow. and release your piece into the dish. Those are pretty simple. They can be done really quickly. But of course, we're not always that lucky to have that, and show in the next little video. Oh, that's the same one. Can you move to the next video? There we go. So this is a biopsy through the side door. So this is going to play really slow so I can talk through it. So this demonstrates a couple of things. You've got your ICM outside, which is not great. You don't have super easy access to the trophectoderm from that outside. So we're going to go in and make another opening in the zona. One thing that's really important when you do these types of biopsies is that where you're working needs to be in the proper plane, because you can laser all day long, and if you're not in the proper plane, you're not going to laser anything. So we're going to make a small opening in the zona here, and this is at a pulse of 400, and then come back, and you can see the part that's expanded outside the embryo is up higher than the other. So it's really important that where you're biopsying is in the proper plane. So I'm just going to pull out a small piece here, and we're going to go back up to the laser power. But it's important, you got to be careful with these, because there is a possibility you can pull the whole embryo out of that hole as well. Sometimes you don't even have to be rough to do that. But you want to be careful that you're not pulling out too much. And as you laser and it collapses, you'll see that some of it might start to slip out a little bit more. This works really quickly once you learn the technique. And we're just going to release the piece into the dish. And the next slide, please. So we get a lot of requests for thaw biopsy revits, and I'm not sure if any of the other speakers will address this. I hope that somebody does. Why would somebody do this to perfectly nicely frozen embryos? They might come back for a second baby and they want to do testing. They might have failed their first cycle with untested embryos, and we have to do it for no-call embryos. So you, as an embryologist, need to decide, when do you thaw and when do you biopsy? So at RSC, we do these first thing in the morning before we start other thaws. And the reason for this is we want to keep them together with our other biopsies so it doesn't interrupt the day so much. And we gotta give them a little bit of chance to re-expand so you can actually see the difference between where the trophectoderm is and where the ICM is. But you don't have to wait for full re-expansion. We like to track what the freeze day was, because it's really easy to thaw a bunch of embryos and put them into a drop. But we know that our day 5 embryos have a higher euploidy rate and a higher pregnancy rate than the day 6 biopsied embryos. And so we like to keep track of that for the physicians. Very important for you in the laboratory to set realistic expectations for both the physician and for the patients. Not all the embryos are going to survive the warming process, although, you know, I think most people, it's not uncommon to see rates of 98% and above on a routine basis. So that's not really such an issue. But not all embryos are going to be biopsyable after this. Hopefully, most, if not all of them, will be. But occasionally, you might not have one that you can get a decent biopsy. You have the option of putting them in the incubator and waiting another day. But we found often that does not really help them. They don't generally do very well with that. And the next slide is actually a little video of an embryo, and you can see how small it is. And this embryo had some extraneous blastomeres that didn't come along. So, you know, we kind of push and pull a little bit to get a little piece. These are super easy to pull out of the zona, and you want to be really careful of that, because if you're biopsying something this small, it's even more difficult. I think David and Tony both mentioned that day 6s are a little bit harder to biopsy just to get through the cells. We found that these tend to be a little bit more difficult too, but they're really doable. And pregnancy rates are good. Euploidy rates are about the same, whether they were previously frozen or not. The next slide, please. This is one of the most important steps prior to tubing, and if not the most important step. We do not have an electronic witnessing system. Our dutiful embryologists do this together. When we set this up, we have the embryologist who tubes requires a second witness, and that person goes together with the tubing embryologist and looks at the physician order, first of all, and look at the genetics lab, because we don't use a lot of genetics labs, but we do have more than one. And so it's really important that you know which genetics lab you're using. They will both verify the dishes with the name and the embryo number. We verify the kit, that we have the proper kit from the genetics lab, as well as the wash buffer. And then finally identifying the tubes themselves. In the next slide, please. This is how we set up our rinse dishes, and I'm looking forward to hearing the other speakers afterward, because everybody does this a little bit differently too. The dish on the right, Scooby-Doo's dish, is how we set up our biopsy dishes. So we biopsy 2 embryos at a time. On the left-hand side, you're going to see these two fat drops here are for rinsing, and your pipette, and then these are for rinsing the cells. A lot of people will use 1 drop. Lots of right ways to do this. Again, at the bottom, a couple different ways, 3 different ways you can set up your tubes. One, you can hold your tubes in your hand. The middle dish, or the middle one, is just laid down on the bottom of the dish. We do pre-fill the tubes with 2 or 3 microliters of wash buffer. And then the dish on the right is just, instead of using your hand to hold the dish, you can park it up against the edge, or to hold the tube, you can park it up against the edge of the dish. There also is a little device that you can set in your dish that serves the same purpose. So again, lots of right ways to do this. Practice and see which one works best for you. And in the upper right picture is the kit. So this video is, want to point out that this video coming up is a tubing video, but that blob in the middle is not a piece of trophectoderm. It's actually a wad of cumulus cells for demonstration purposes only, because it's a lot easier to see something that big. So picking it up with a stripper tip, we're going to move it into a rinse drop. And then the next thing we want to do is get the oil off the pipette. And you can do that in a variety of ways. We do it by dragging, and you can see all that oil coming off. And we're going to talk about why that's important in a little bit. You can drag it through, you can pipette it up and down, however you like to do it. When rinsing, so you're going to pick up media from the next drop, pick up your cells, and then put them into the fresh drop. You can puff them around like that, which may be better than pipetting them up and down, because they tend to be a little bit sticky. But again, we're going to rinse them through the drops, puff it around a little bit, pick up some clean media, and then we're going to get ready after one more rinse to put it into the tube. And again, this is a big piece of cumulus mass. So just for demonstration, this is Scooby-Doo's tube with a little bit of media down at the bottom, and you want to just deposit that right there. So that works pretty well. On the next slide, please. So hints for tubing and biopsy. Again, take the time to set up your equipment, gather your supplies, check the ranges on your joystick. Boy, there's nothing worse than getting to the end of a difficult biopsy and finding out you're at the end of your range, and now what are you going to do? Make sure your laser is aligned. Align your microtools in the proper plane. This one sounds like a no-brainer, but it's really not. Before you move on to your next embryo, whether you're freezing or tubing or biopsying, make sure that the embryo is in the dish it's supposed to be in, and the tubing piece is in the dish it's supposed to be in, so you don't accidentally pick up your tubing piece when you're moving on to your next, moving your embryo into the culture dish. And always be sure to remove the oil from the stripper tip. The next slide, please. So again, practice, practice, practice. You can never practice enough. Where are you going to find training materials for this? You can use embryos that were released to the lab for research and training. You can use embryos that were consented to be discarded, and embryos that were aneuploid with patients' consent that they're not going to use them or move them to another center. When someone's training, they can take the biopsy pieces, culture them overnight in a dish, and look in the morning, make sure they're still alive. And finally, culturing the embryos overnight and looking for expansion or development. They may not be that nice because they maybe weren't that nice to start with, but they should still be alive and hopefully with some expansion. This is one of the most important things when you're learning, is to keep the piece. And by the piece, I mean your little piece of tissue. Check for goobers, and we all know what little goobery things are. It could come out of your stripper tip, it could be in your media, it could be in your dish. Before you start, check your drops for goobs and take them out, get rid of them, so you're not confusing your piece with the little blob in there. Keep your piece away from the edge of the drop. Keep your piece away from oil and air bubbles. Those are for sure the enemy. Don't aspirate the piece too far up your stripper tip, because once it's gone, it's probably gone. This last one is really a training thing, and this is a practice step. You need to train your eyes to go through every step of the process without having to move the magnification up and down and changing the focal length, because it's a really easy way to lose your cells in the microscope and during the moving process. So take the time and train yourself, train your eyes that you can see the piece every step of the way, and that will make your life so much easier. Next slide. Training and KPIs, super important here. We do an amplification verification with the genetics lab with all of our embryologists before they're turned loose to be tubing cells. We also do it if we have any of the any visitors that come to the lab. Really important that even though, you know, they've worked other places and know what they're doing, we need proof of that. Monitor your no-call rate, like Tony mentioned. Monitor your embryo survival rate by tech, and also monitor the pregnancy rate. And, you know, I believe it was David in the first lecture talked about, you know, is this piece too big? Is it not too big? You know, are we damaging the embryos? It doesn't appear to be. And if you can prove that your technique works because you have low no-call rates and you have good embryo survival rates and you have good pregnancy rates by every technician doing the work, I think you're in great shape. And the next slide. Know your data. So for example, you know, between January 1st and September 30th of this year, we biopsied 4,449 embryos. We know about half of those are on day 5, about half on day 6. We do very little day 7 culture, and so we have very few embryos that are biopsied on day 7. 72% of our patients do PGT. This is often patient choice. We can argue that one way or the other, upside down all the way if you want, but oftentimes patients are interested in PGT, whether we think they need it or not. No call rate out of that set of embryos was 13, so 0.29%, with no difference between biopsy techs, which again, that's one of those things that you want to be sure everyone's doing things the same way. Next slide, please. And finally, I think this is the last one. Know your data. What is the euploidy rate for your different age groups? And so you can accurately have a conversation with your patients. So this is broken down literally by, you know, by every age. That's supposed to be 39, not 238. Sorry about that. But it's good to have this information to the patient because you can present realistic expectations for them. Next slide. Wash your paws, wear your mask. Thank you.